Every year, millions of dollars are spent on these like cosmetic laser treatments to fix a highly stigmatized problem, which is this physical feeling of vaginal looseness. And the marketing always promises this quick surface level fix to, tighten up aging tissue.
Right, which sounds great until you realize it might not be a surface issue at all.
Exactly. Because what if the medical literature reveals that this sensation of being loose is actually caused by something pushing its way in? I mean, what if the root cause isn't loose skin, but a herniated bowel pressing forward into the vaginal canal?
Yeah, when you step back and look at the actual anatomy of what's happening there, it completely changes the conversation. You realize very quickly that we aren't talking about a cosmetic issue. We are looking at a really profound structural anatomical failure inside the pelvis.
So, welcome to today's deep dive. We are tackling a topic that is, frankly, incredibly common but shockingly underreported, mostly because it sits right at that intersection of intimacy and bowel functions, which are, two things people are historically conditioned to feel deep shame about.
Oh, absolutely. The stigma is huge.
It really is. So, our mission today is to cut through that stigma and investigate a very specific question. Can a structural weakness in the posterior vaginal wall, so the back wall of the vagina, directly cause a physical sensation of looseness?
And to answer that, we are synthesizing a massive stack of clinical literature. We're looking at joint reports from the International Urogynecological Association, the International Continence Society, and comprehensive clinical reviews on pelvic floor dysfunction, plus NHS patient guidelines.
Basically, we are completely bypassing the marketing pamphlets and looking strictly at the mechanics of the human body.
Exactly. Just the facts.
And if you are dealing with this, we just want to acknowledge right up front that you are far from alone. Countless people endure this in total silence, assuming it's like just an inevitable part of aging or having kids. But today, we are bringing it out into the open to look at the reality of what your body is actually experiencing.
Yes, and before we can figure out if a weakness in the back wall causes that feeling of looseness, we really have to isolate our terminology. The medical literature relies on two very specific concepts here.
Right, which are vaginal laxity and posterior vaginal wall prolapse.
Let's define vaginal laxity first.
Ah,
The Global Urogynecology Guidelines explicitly define this as a complaint of, quote, excessive vaginal flaccidity.
okay, excessive flaccidity.
Right, and what is crucial to understand here is the medical philosophy behind how this is categorized. The clinical literature views laxity as a somatic physical dysfunction.
Which is a huge deal, right? Because for decades, women's pain or discomfort in this area was often just dismissed as psychogenic, like, oh, it's all in your head, or it's just relationship anxiety.
Exactly, and the modern literature firmly rejects that. It is categorized as a real physical sensation that a patient is genuinely feeling.
Okay, so then sitting right next to laxity, we have posterior vaginal wall prolapse, which is commonly known as a rectocele. So if you visualize the pelvic floor muscles, they form a sort of biological hammock spanning the bottom of your pelvis, right? And it's holding up your bladder, your uterus, your bowel. And because we walk upright on two legs, gravity is just constantly pushing our internal organs down onto this hammock.
Right, it's a lot of constant pressure.
Yeah. And between your rectum and your vagina, there is this very strong fibrous layer of tissue, a fascia. So if the fibers of your pelvic floor stretch out or tear, the hammock sags. That fascia wall weakens and the rectum literally bulges forward, pushing into the vaginal space.
And the clinical distinction here is really the foundation of how doctors approach treatment. Laxity is classified as a symptom. It's subjective. It's what you, the patient, feel and report.
Got it.
But prolapse, however, is a sign. It's an objective anatomical event. A doctor can use instruments to visibly see and physically measure the bulge of the bowel during an exam.
Okay, let's unpack this though, because, wait, if a patient is feeling loose and the doctor performs an exam and physically sees a prolapse, aren't we just talking about the exact same thing using two different dictionaries? Why does the medical literature fight so hard to treat them as completely separate medical conditions?
Well, it's because the presence of one does not guarantee the presence of the other. And that can really trap patients in a diagnostic maze.
Oh, interesting. How so?
Well, you can have a patient report severe laxity, but when the doctor looks, there is no visible prolapse yet. And conversely, a doctor might find a significant prolapse during a routine exam on a patient who feels absolutely no looseness at all.
Wow. Okay.
But, and this is really the anchor for our entire deep dive today, the clinical evidence overwhelmingly proves that the anatomical event of a posterior prolapse is a massive primary driver of the symptom of laxity.
Okay, let's follow the logic on that, because on its face, that sounds like a paradox to me. If a rectocele is a literal bulge of the bowel pushing into the vaginal space, taking up physical room, wouldn't a mass sitting inside that space make things feel tighter or like more full? Why does a physical bulge make things feel looser?
Yeah, no, it seems entirely counterintuitive until you look at how the nervous system and the pelvic floor register tension.
Okay.
So the opening in the pelvic floor is called the levator hiatus, and wrapping around this area is a specific muscle called the puborectalis muscle, which acts almost like a sling. It defines what urogynecologists call the high-pressure zone of the vagina.
High pressure zone.
Yes,
Yeah.
and this high-pressure zone is what provides structural tension.
Tension is the key word there, right?
Right.
Because tension is what gives the brain the sensory feedback of tone or tightness.
Exactly. So what's fascinating here is when the posterior wall and the perineal body, which is that thick central tendon sitting right between the vagina and the anus, when those are damaged or weakened, that puborectalis sling loses its anchor. The high-pressure zone is completely lost.
Oh, I see.
So while the physical bulge of the bowel itself might feel like a heavy lump or a dragging, aching pressure in your pelvis, the structural failure of the fascial wall means the entrance and the vaginal walls have lost all their anchoring support.
Oh. Okay, think of it like a trampoline. Like the mat of the trampoline is your vaginal wall, and the heavy-duty springs connecting it to the frame are your fascial support system and levator muscles.
That's a great analogy, yeah.
So if the springs on one side completely snap, the trampoline mat loses all its tension. It just hangs there. And if you then roll a bowling ball onto that broken side, you suddenly have a huge bulge pushing down, taking up space. But the trampoline mat itself is still loose and floppy because the structural tension holding it taut is just gone.
That is exactly it. Without that structural tension, the sensory feedback during intercourse, or honestly even just walking around in daily life, registers to your brain as loose. The actual volume of the bulge doesn't matter. The body senses the lack of structural resistance.
That makes so much sense. And the sources back this up with some staggering numbers, actually. There's this massive comprehensive study using the EPA-QPF questionnaire tracking over 2,300 women.
Oh yeah, that study's huge.
Right. And it found that 38% of those women reported vaginal laxity, and that feeling of looseness wasn't isolated. It was significantly clinically associated with objective symptoms of prolapse.
And the clinical review from the RECGP explicitly lists vaginal laxity or looseness as a primary symptom of prolapse. They note that this specific symptom is heavily noticed in younger women in particular, and it has a profound impact on sexual function.
So this means the communication between patients and doctors needs to be incredibly precise, doesn't it?
Absolutely. Because if a structural weakness in the back wall creates this exact sensation of laxity, understanding how that weakness happens in the first place is really the only way to prevent a dangerous misdiagnosis.
Right, because the shared root causes for both the feeling of looseness and the actual bowel prolapse are identical.
Yeah. And the most significant shared cause, by a pretty wide margin, is vaginal childbirth.
Which makes sense mechanically.
Right. The mechanics of what happens to the levator hiatus during delivery are just extreme. To allow a baby to pass, the pelvic floor muscle has to undergo a degree of stretching that would normally literally rupture any other skeletal muscle in the human body.
Wait, we really need to pause and let that fact land, because if you subjected your hamstring or like your bicep to the exact same stretching forces that the pelvic floor endures during childbirth, the muscle would snap in half.
It would completely tear, yes. The amount of trauma your body absorbs is just monumental, and the risk profile skyrockets with instrumental deliveries.
Like forceps.
Exactly. If a doctor has to use forceps, for example, the risk of major pelvic floor trauma jumps to between 30 and 65%. The forceps and the delivery process essentially overstretch or tear that levator hiatus, leading directly to that loss of tension we talked about.
Wow.
And you feel that loss of tension as laxity today, but it really sets the stage for a full bowel prolapse down the line.
But childbirth isn't the only structural threat, right? Because you can experience this even if you've never been pregnant.
Oh, for sure. Aging and menopause are huge factors. Estrogen plays a massive role as a biological scaffolding maintainer. So as we age, the sharp drop in estrogen weakens the body's collagen production.
So the tissues just get weaker.
Right. The fascial tissues in the pelvis become thinner, less elastic, and much more prone to sagging under the constant weight of gravity. And then on top of that, you have lifestyle and chronic conditions that cause sustained intra-abdominal pressure.
Oh, like chronic straining. Every time you bear down, you are pushing pressure straight into that posterior wedge.
Exactly. Chronic constipation is a prime offender here. If you are straining on the toilet every single day, you are repeatedly pushing the bowel violently against that thin wall of fascia. And over years, it stretches and
And I
breaks.
guess the same mechanism applies to what? Heavy lifting?
Heavy lifting, a chronic cough from asthma, or even a lifetime of smoking, all of this relentless downward force mechanically breaks down that posterior wall.
So what does this all mean? It brings us right back to the danger of that symptom mismatch we opened with. The sources are highly critical of marketing language around vaginal rejuvenation or tightening. They actively warn against it because it aggressively oversimplifies complex anatomical
Yeah,
failures.
it's really dangerous. A patient might go to a boutique clinic seeking a cosmetic laser treatment because they feel loose, fully believing they just have aging skin. But if the actual clinical priority is a herniated bowel pressing through a broken fascial wall, a surface-level laser isn't going to do a single thing to rebuild that structure.
It's like taking your car in because the steering feels loose, and the mechanic just puts a tighter cover on the steering wheel instead of checking to see if the axle is broken.
That is exactly what it's like. You are treating the surface and ignoring a collapsed foundation. This is why getting a proper medical diagnosis is critical, rather than self-diagnosing based on a marketing ad.
Right.
And to help with this, our sources point out a highly specific differential symptom. It's a major red flag that helps a doctor instantly distinguish a rectocell from simple tissue aging. It's a medical term called splinting or digitation.
Okay, I remember reading the health guidelines on this and being struck by how intense this reality is, yet it is almost never talked about in public. What are the actual mechanics of splinting?
So splinting occurs when a patient feels that looseness and dragging sensation,
Right.
but they also find they cannot have a normal bowel movement because the fascial wall has failed. When they try to push, the stool doesn't go straight down and out the
Oh,
anus.
it gets stuck in the bulge.
Yes, it pushes forward, getting trapped in the pocket of the prolapse, bulging into the vagina. So to successfully pass the bowel movement, the patient has to physically insert their fingers into their vagina or press very firmly on their perineum to manually push the bowel back into place.
Oh my God. You are artificially acting as the broken fascia wall. Like your fingers are providing the resistance that your torn tissue no longer can, just to redirect the stool downward.
That's exactly what's happening mechanically.
It's incredible that something that mechanically extreme is happening to so many people, yet because it happens in the bathroom, in total private, patients might think it's normal aging and just never tell their doctors.
The shame is a massive barrier to care here.
Yeah.
But if you are splinting, no amount of cosmetic rejuvenation is going to solve your feeling of looseness. The wall separating your bowel and your vagina has failed. It requires a mechanical solution.
So since we know the issue is a fundamental loss of structural tension, repairing the problem can't just be about surface tightening. You actually have to rebuild the foundation. What does that look like medically? I mean, how do we fix both the anatomy and that sensation of looseness? Our sources lay out a pretty clear pathway, right? Starting with conservative measures.
Yes. The absolute first line of defense is pelvic floor physical therapy. But it's not just about telling a patient to do Kegels at home. Research shows that up to 32% of people actually cannot contract their pelvic floor correctly.
Wait, really? A third of people?
Yeah. When instructed to pull their pelvic floor up and in, they instinctively bear down. They push out.
That means a third of people trying to proactively fix their prolapse and laxity are actively making it worse. Every time they think they are doing a Kegel, they are actually pushing the bowel further into the vaginal wall.
Which is why the clinical literature emphasizes working with a specialized physical therapist using biofeedback.
Now, how does biofeedback work?
It uses sensors placed in or around the vagina that connect to a monitor. You can physically watch a screen to see if your muscles are pulling up and creating that high pressure zone, or if you are accidentally pushing down. It basically retrains the brain's connection to the pelvic floor.
That makes total sense.
And alongside this, doctors often prescribe topical vaginal estrogen to plump and strengthen the tissues directly, especially for menopausal patients. There is also the option of a pessary.
Right, which is basically an insert.
Yeah, a firm, removable silicone device inserted into the vagina that acts as an internal scaffold, physically holding the bulging bowel back in place.
But let's say someone has a large rectocell. They are splinting every day to manage their bowel movements. They feel a constant lack of tension, and the biofeedback and pessaries just aren't enough to restore their quality of life. What then?
Then the conversation shifts to surgical intervention. For a posterior wall weakness, the gold standard procedure is typically a posterior colporrhaphy. The surgeon makes an incision in the back wall of the vagina, locates the stretched out, weakened fascial layer between the bowel and the vagina, and they repair it.
And how do they repair it exactly?
They use a technique called popcation, which is essentially folding the stretched tissue over itself and suturing it together. It's much like sewing a dart in a piece of clothing to pull it tight and restore tension.
And crucially, the clinical reviews note this is generally done using the patient's own native tissue, right? Completely avoiding synthetic mesh.
Yes, historically, synthetic mesh was used heavily in pelvic surgeries, but it led to severe, widespread complications. The mesh was eroding through the vaginal wall, causing chronic pain and infection. So the medical community has largely pivoted back to using the patient's native fascia for posterior repairs.
That's reassuring.
And often, this colporrhaphy is combined with a perineorrhaphy, where the surgeon repairs the damaged perineal body at the entrance of the vagina, physically rebuilding the anchor for that puberectal sling we discussed earlier.
So by physically rebuilding the anchor and folding the stretched tissue back into a tight structure, you restore the tension. And the clinical data on how this impacts the feeling of looseness is incredibly validating.
It really is.
Yeah, one longitudinal study tracked patients for 5 years after having native tissue posterior repair. And the number of patients reporting symptoms of vaginal laxity absolutely plummeted. It went from 25% before the surgery down to just 8% 5 years later.
That's a massive drop.
And they also saw huge drops in painful intercourse and bowel dysfunction.
Because it's direct proof of the mechanics.
Yeah.
By fixing the underlying structural failure of the prolapse, you effectively eliminate the sensory symptom of laxity. The foundation is rebuilt, the tension returns, and the looseness goes away.
It is so empowering to see the data validate the patient experience like that. But looking at all of this, does this mean everyone experiencing a feeling of vaginal looseness needs to rush out and get a posterior repair surgery?
If we connect this to the bigger picture, absolutely not. Surgery is an invasive, major step. The global guidelines are universally clear that surgery is strictly reserved for highly symptomatic cases where a patient's quality of life is severely impacted and where conservative therapies have thoroughly failed.
Right.
And more importantly, a surgeon won't operate until you address the behavioral root causes.
Oh, because if your rectocele was caused by decades of chronic constipation and you undergo a major structural repair surgery but continue to strain on the toilet every single day, well, you are eventually going to violently push that bowel right through the brand new surgical stitches.
Exactly. Sometimes treating the chronic constipation to stop the daily straining is the absolute most vital first step to protect those vaginal support tissues. You simply cannot out-surgery bad mechanics.
It really is an entire interconnected system. You can't just treat the feeling in isolation. Which brings us to a perfect moment to summarize exactly what we've unpacked today. We set out to investigate if a weakness in the back wall of the vagina can cause a physical sensation of looseness. And the clinical literature provides a resounding yes.
A very clear yes.
Vaginal laxity isn't just an isolated cosmetic issue, and it isn't an inevitable part of aging. It is frequently the direct sensory feedback of a structural failure, a critical loss of physical tension caused by a herniated bowel pressing into the vaginal canal.
Yeah, by distinguishing between the subjective feeling of laxity and the objective physical reality of a prolapse, we see exactly how the mechanics interact. The bulging bowel breaks those biological trampoline springs we talked about. It destroys the tension of the vaginal walls, and the brain registers that structural collapse as a feeling of looseness.
So if you are listening to this right now, feeling that lack of tension, experiencing a dragging ache in your pelvis, or if you recognized exactly what we meant when we described having to manually assist your bowel movements, you do not have to endure that in silence.
No, absolutely not.
You are experiencing a documented, mechanical, anatomical issue. Advocating for a proper medical diagnosis to check your structural foundation is your right. And honestly, it is vastly more effective than falling for quick fix marketing terms that just want to sell you a surface level laser.
Accurate medical care starts with speaking up about the mechanics of what your body is actually doing, no matter how embarrassing it might feel to say out loud.
Now, before we wrap up, we want to leave you with one final, deeply fascinating medical paradox found buried in the urogynecology reports. We've spent this entire deep dive looking at how the body manages pressure and tension and structural collapse. Well, there is a complex condition mentioned in the surgical guidelines called occult or latent stress incontinence.
This is a stunning example of the domino effect inside the human pelvis. Stress incontinence is when a patient leaks urine during moments of sudden intra-abdominal pressure, So coughing, laughing, or sneezing. But occult means hidden.
Hidden incontinence, how does that work?
Well, sometimes a patient will present with a massive pelvic organ prolapse, but when the doctor asks about their bladder, the patient proudly reports zero urinary leakage at all.
They think their bladder control is just made of steel. But the reality is, the prolapse is so massive and the organs have dropped so far down that the prolapse has physically kinked the urethra shut.
Exactly. Think of it exactly like dropping a heavy boulder onto a garden hose. The
Mm.
water just can't get through. The catastrophic structural failure of the prolapse is artificially clamping the urinary tract shut, preventing the leakage.
And the paradox happens in the operating room. A surgeon goes in, performs a flawless procedure, lifts the prolapse, restores the anatomy, and sews the fascia back where it belongs.
Like the boulder is lifted off the garden hose.
Yes. The kink is completely removed.
Yep.
And suddenly, during recovery, the patient discovers they have a severe hidden urinary incontinence problem that they never knew existed because the prolapse had been masking it for years.
You rebuild the foundation and suddenly you realize the plumbing has been broken the entire time.
It is wild. It really leaves you to ponder the incredibly complex, interconnected web of the human body. Like, how often does our body's failure in one area secretly mask a completely different failure in another?
It's a great question.
Just like how a bothersome feeling of surface looseness can actually be the mask for a herniated bowel quietly pushing its way in. So next time you see an ad promising a simple cosmetic fix, maybe ask yourself what structural secrets might be hiding beneath the surface.